I am going to introduce the moderator for our next session, which is Shared Care in the Policy Landscape. And I have the pleasure of introducing Dr. Robin Stone, who founded the Leading Age Center for Applied Research, which is now the Leading Age LTSS Center at UMass Boston in 1999, and served as the center's co-director and senior vice president of research at Leading Age until her retirement just a few short months ago. Congratulations, Robin. Congratulations, Robin. And in her role and in her career, she is engaged in policy development and applied research for more than 40 years, serving in several capacities, such as at the U.S. Department of Health and Human Services as the Deputy Assistant Secretary for Disability, Aging, and Long-Term Care Policy, as well as the Assistant Secretary for Aging. So please welcome Dr. Robin Stone.
I know that Jenny was worried I didn't have any paper in front of me. And Catherine and I were talking about the fact that some of us still wing it. So, and now since I'm retired, I can sort of do whatever I want. There's a lot of you out in the audience, and two of the three of the panelists I know very well. One I met recently, and I feel like I've known her forever too. I want to do a couple of things before I call up the folks, and that is just to give you the context of my pessimistic optimism, and that's the way that I define myself. I have about 50 years, literally, of experience in the same sectors because I've been working in long-term care policy since I was 26, and I'm now 76. So it's literally 50 years. It's really hard to imagine it. I think in some ways we've made tremendous progress. I look at the wards that we had here 35, 40 years ago with people being tied down. I think about the fact that family caregiver wasn't even a concept. I think about the fact that, this is an example of where we were able to scale. We actually did the cash and counseling demonstration work starting in the late 80s. And when I was in the department, we actually funded the first 3 demonstrations in New Jersey, Arkansas, and Arizona. Yeah, Arizona. And we now have consumer direction in all 50 states in some way, shape, or form, and as well as the District of Columbia. And that was actually a scaled demonstration that was funded jointly by the department where I was and the Robert Wood Johnson Foundation. So there is great potential, I think, for scale. But I think for the most part, what we see here in the United States is either one-offs or small programs that get funded, have an evidence base, and are really hard to keep funding beyond the early adopters. And I've sort of come to the conclusion in many ways that maybe most of the policy work ultimately happens at the local and maybe the state level. And we're very, very diverse in this country. We have 51 states. Some of our states are as big as many countries in the world with tremendous diversity. And for us to think that we're going to have one standardized solution for these issues is probably unrealistic. I often think, man, I'm happy that LBJ was around in 65 when he got Medicare through, because we would never have Medicare today. And we are really lucky that we have a universal health care program for people over 65 and younger people with disabilities, because I don't believe that that would happen right now or any time in the foreseeable future. So given that, does that say we can't do anything in policy? And I don't believe that that's the case. So with that, I'm going to call up our 3 folks, Rita, Pam, and Norma. And any way you want to sit. I'm going to do a really brief intro that I'm actually reading from the blurbs that you have. So I'm not going to read the whole thing, just the intro so you know who they are. And then we'll move on to some of the questions, and hopefully we'll get some good conversation and dialogue as well. Rita Chilla is the Senior Director of Caregiving at the AARP Public Institute. The other PPI that I know, I was sitting next to somebody from PPI at lunch, and turns out it's the Progressive Policy Institute, which for all the years I've been living here, I didn't even know that existed. So another PPI. In her role, she drives the development of family caregiving initiatives by providing content expertise both within AARP and in partnership with a range of external collaborators. And I know Rita for many years, and I can agree with that statement. Norma Coe is a professor in the Department of Medical Ethics and Health Policy at the Perelman School of Medicine, the director of research at Penn LBI, and the co-director of the Population Aging Research Center. And I think most importantly, her focus here brings a focus on health economics and public finance. So we can really start to think about how do we think about the financing issues that underlie either the ability for us to have shared care or create significant systemic barriers to making that happen. And then finally, Pam Nadish, who was sort of somewhat of a last minute addition, but I've known Pam probably since you were at Hickory in
Cash and counseling.
Oh, shit. Okay, with Cash and Counseling, and then with DNS of New York. So, and then with NCOA, she's been at a number of places over the years that I've also worked with. So, but she's currently an associate professor in the Department of Psychology at the Manning College of Nursing and Health Sciences at UMass Boston, and is part of our LTSS UMass Boston group. So with that, I'm going to sit down and start the conversation. And I think the first thing that I want to ask about, it starts with Medicare and Medicaid policy. If we think about shared care, which in the context of this conference is really about the family caregiver and the direct care worker really coming together. They're already together in an informal way, and you heard an example, a really great example of when that informal becomes really formal, when it was really a success of the two working together. But that is probably at this point the exception rather than the rule. It also obviously depends on having a direct care worker. I actually call the family caregiver, and I did probably the first national study of family caregiving in 1985. I used the 1982 long-term care survey. And quite honestly, a lot of those statistics have not changed one whit since 1982, which was the first year of that survey. So I know a lot about family caregiving, and I don't think that many people really still understand that they are the foundation of our long-term care system. And that has never changed. The whole formal system is a fraction of the services that are provided by families. The second order of caregiver is that frontline professional who does 60 to 80% of all the hands-on formal care in our system. So between that family and that frontline person, that is our system. And I've always thought that it would make a lot more sense if they were really working much more in sync, assuming that somebody has a direct care worker, which not everybody does. So shared care is dependent, number one, on actually having somebody to share your care with. And particularly that's true in the home. I think the nursing home and even assisted living has a little bit of a different flavor because you're in a building and you have, for all its warts, you have other folks around. In the home, you are basically either a direct care worker alone with people and nobody else there, or there was an underlying family caregiver who is then working with the direct care worker. So if we think about that, what can Medicare and Medicaid do? Or what can financing do? What can payment do? What can some of the changes in the rules and regulations that currently permit certain things or don't allow certain things? How might we think about using both of those programs, one of which is more or less universal, the other which is obviously going to vary tremendously by state? How do we think about those levers are there any levers that we could really think about that might help us with this shared care, making it more formal, moving it from the informal to the formal? And I'll just ask everybody to just comment on that, starting with you, Norma.
Sure, that's just the 40-minute question right there. So it's a pleasure to be here and be stumped in front of everyone here today. And I think just to start, like you said, I think the first thing to remember, and everyone in this room knows, is, we did a study looking at, formal care and informal care in the home. And, of those receiving formal care that had disabilities, 2/3 of them were also receiving hands-on care from family members as well. So we can talk about things about shared care, but we act like they're actually completely independent. But the vast majority of people who are getting paid care in the home are actually also being touched by their family members. And I think that's really important. This is universal, despite the fact that nothing else about long-term care is. We have different payers, we have different providers, we have different, everyone's been calling this a system, which I think is very, very generous. Like what is in place depends on where you're sitting, how much money you have, what hospital system you're in, who's your insurer, you name it, it's all dependent, which makes it really difficult to make these big policy recommendations because everyone is affected differentially. But I will say we did look at the data, and we found that people who are getting care by both family members and formal caregivers do actually fare better in their long-term outcomes, both in terms of mental health and in terms of physical health. And so bringing at least some, evidence-based, this is not a payment model, this is just what is happening in people's homes, you get better outcomes. It starts to build an evidence base to say that we need to be thinking about how do we actually make this possible, get people who don't have insurance for formal caregivers perhaps need some and mechanisms to pay for it, and get those workers in the home and get better outcomes for both patients and, we didn't study it yet, but probably the family caregivers as well.
Yeah.
My own. Hi there. This is such a great meeting. So many wonderful people here. I think I'm really grateful to be part of it. So there's so many different angles I can take on this. The first thing I just want to comment on something Robin said about how LTSS is local. I did a paper a while back, and I was looking at a lot of different countries, and in every country, pretty much, it's the ones I looked at anyway, it's local. So people sometimes look to other countries and kind of assume that they do it better than we do, but you still have the same local variation. And where you have local variation, you have inequity. So it's just something to think about, because the richer regions always have better services than the poorer regions. And the poorer regions often have a predominance of older people because the younger people go to the cities. And so you have that same issue that we have here. So we're not unique in that at all. Okay, so other stuff about payment systems. We don't have a lot to work with right now. So that's kind of the big problem that we're facing. We're in this time period where there isn't going to be any funding. So we need to think about, what can we do within this context? And again, we're not sure how much different forms of managed care are going to be affected by this, but we do have some models of integration. And as part of those models, they have interdisciplinary care teams. And that is a lever. I mean, you can use those interdisciplinary care teams. Somebody was talking earlier about integration into primary care teams. But it's often common practice in many of these Medicaid, Medicare managed care teams to utilize interdisciplinary care teams as a care coordination mechanism. And that seems to be a natural place where you can involve the direct care worker, you can involve the family member, and it's a shared space for people to exchange information. So that's kind of one very small idea that's not going to affect a heck of a lot of people, because there just aren't so many of those models. The other thing I sort of picked up on was, once again, one of these perennial issues. So when I was at NCOA way back in whatever, 98, whatever it was, we did a whole thing on nurse delegation. And that too was mentioned earlier today, that this is a very simple reform that can be made, that where you can, and this is all down to the states as well. So the states need to be open to certifying direct care workers to do some level of medication administration. That's a teeny little tweak that might help in this context. And just kind of big picture financing stuff, it's obviously not going to happen anytime soon, but we still need to be thinking about what the models are that are coming down the road that might actually serve to support LTSS. And obviously we have, in the States, we've got the Washington Care Model. And quick advertisement, I am a co-chair of the Long-Term Care Discussion Group, and we are going to be hosting a session on the recent advances in the Washington State Model. So if anyone's interested, please do join us. I'm happy to share the information with you. But other than that, there isn't a lot happening at the state level, despite a lot of interest. Folks from California, you guys have been working on that for a while, and I don't know that there's anything much to show for it. I hope something comes of it over the longer term. This is just something we're going to hope that states pick up. And again, Wendy, you're going to probably talk about this later, so I won't talk about it too much. All right, I think that's my 2 cents to start with.
I'll jump in. First, I want to thank Dr. Fabius and team for doing this important work on shared care and pulling us all together. To know me is to know that when I talk about policy, it's policy, but we have to lift it, right? We have to lift it up off the pages and make it real for people. And I think one of the realest things, as a former family caregiver myself, I cared for my mother for 15 years. She lived with frontotemporal dementia. It really is about recognizing the increased complexity of care that family caregivers are providing. I think everyone in this room is fully cognizant of, what family caregivers do, but recent research from AARP, from the National Alliance for Caregiving, and others in the field really show an increase in that complexity of care. We're talking about doing insulins at home. We're talking about heavy medication management, things that family caregivers never necessarily had to do en masse in the way they're doing it now. And we're hearing from these family caregivers that they're not getting training in how to do this. And there are not enough direct care workers in the home, paid direct care workers that are really able to provide that support. And so, when I think about shared care, primarily I'm coming at it from the family caregiver perspective and how we can improve the support that they receive, both from having someone in the home and creating systems so that there are enough workers that can come in the home and alleviate that. But then also, what are policies and practices that can support that need of the family caregiver? And one that I will speak to on a federal level are Medicare caregiver training services codes. And this is an opportunity for providers to get reimbursed. Now, every type of provider is not yet not yet able to be reimbursed, but it's a start. It's a recognition that caregivers need support, and that in policies that we're talking about caregivers, their needs really need to be centered. And so I think that Medicare CTS codes is a really important model for us to look at. AARP, actually next week, we're coming out with a report to talk about what the utilization looks like. We can have a policy, but if I go in a room of providers and I'm talking about this, and afterwards they come up and say, where can I find that code? There's a problem, right? Because they don't know it and they're not able to then use it, and the caregivers receive that support. So I think as we talk about policy, it's also about the implementation of that policy. It's about the utilization of the policy and really working to ensure that individuals that are supposed to be supported by said policies really are.
You know, I want to pick up on that because I think this is such a great point that you make. Training, we've heard the training need, and we got the training need for both the family caregiver and the direct care worker. And one of the things that has always stymied me is why aren't we doing them train together? Not everything is going to be the same, but there are basic competencies that are the same. So if we really want to develop a shared care program, and we have Medicare that at least is putting the camel's nose under the tent to actually look at using Medicare codes to actually develop training, let's think about how we could expand that to actually do the dyad training. I've recommended, by the way, that in many communities, nursing homes have been doing training for CNAs for many years, and many of them are downsizing, but they have a lot of skill sets around education. Why aren't we opening them up as a community center for training both aides in all settings and families at the same time? We could get so much efficiency from literally minimizing some of the dollars that are currently spent and targeting them to these two groups, which could also include things like how do you communicate with each other? Cultural competence between a primarily white family caregiving population in this country and a much more diverse direct care workforce in this country. That's going to change within the next 20 years. But right now, about 70% of all the long-term care population, 75% is white. So your family caregivers are mostly white, and your direct care workers are much more likely to be people of color. So let's think about that. And I'm just wondering how that resonates with you, whether we could use some of our funding streams more efficiently to actually target both populations and give them the skills. I mean, does that make sense to you?
And absolutely. I also think that example is a prime opportunity for where public-private partnerships can be really critical. I think we continue to lean heavily, of course, on state policy, on federal policy, but how can we work with employers? How can we work with nursing homes, private, for-profit, whatever that may be, to really, and health systems, to really come up with some of these creative ways to meet the needs of both groups so that that shared care can actually happen. I think we do spend a lot of time in where that public policy is extremely important. We have to find ways to get creative to be able to provide those training opportunities and other innovative ideas to really make it happen on the ground.
Anybody else?
Yes, another area I think that we have potential for that type of training opportunities is with the move to more care at home. So hospital at home, we're sending people home that would normally be in a hospital. There's going to be nurses in the home. They're going to see their family members. They're going to know how important family members are to the entire existence of this hospital at home program. So maybe that's a good way to just another touch point to realize how important the family members are. And then provide the training either within the hospital at home setting or an analog to it afterwards.
Yeah, I've always been worried about the hospital at home thing because everything that's happening right now is going to put more pressure on family caregivers. As Rita said, care is getting more complex. When you shift to that kind of model, it's going to be really complex. There's going to be a lot on family caregivers, and it's I don't know how sustainable that is.
I'm not saying I'm not concerned. I'm just looking for the bright hope. So that maybe this is where we actually see we can't have hospital at home. We can't use this mechanism. We don't train family caregivers and really understand the fundamental role that they play in health and long-term care delivery system in the U.S.
Well, let's talk a little bit more about this. Let's assume, team-based care has become a buzzword. Most of the team-based care models that I have looked at are really the clinical teams. They most often, maybe sometimes, give some lip service to the family as part of that team. They give absolutely no acknowledgement to the home care aide that may be in the home delivering services as well. So could we envision models that could be tested so that you begin to continue to develop the evidence base? Primarily, as someone was saying, the fellow who's with the Home House Calls program, which is one of my favorite programs in the whole world, could we think about a value-based payment model that actually developed a family care, frontline worker care model where they were truly built into the coordination, the care planning from the get-go, the observation, documentation, and ongoing oversight so that they become formal parts of the team. And you could even build in the mobile app that actually allows for folks to put in those data and share in the communication. So, I mean, I'm thinking about whether we could think about an evidence-based approach that would take, Norma, what you were saying, which is you're starting to develop a database, an evidence base, but we don't really have a strong enough one to say, if we really invested in families and their supports through the front line, they were both trained, and then they really were an important part of the team, would that really make a difference? And maybe that would be a way we could move things forward.
Yeah, and I actually think we do have at least a growing evidence base coming out of the VA system, right?
Yeah.
And we don't talk enough to the VA system, I think. But they've been very progressive in thinking about long-term care, what families need, what direct care workers need, and how do they actually provide care and keep people home as long as humanly possible. And we're just not necessarily talking to them as much as we should. We do have evidence-based models that are working. We just need to transpose it to so it's available to more individuals.
So let me ask another question to all of you in terms of this shortage of the workforce, the terrible stories that we heard, which I had done research in nursing homes, home care, and assisted living for many years, and I have heard horror stories of working short. It is absolutely true in the nursing home. What's probably worse in home care is that you only have one person, and then you get either a call out or you have this revolving door of 40 people. That's just not sustainable. The term consistent assignment has become at least a term for nursing homes. I'm not saying that it's practiced well, but the better nursing homes are really trying to invest in consistent assignment where they really have the CNA developing a relationship with the resident, and that has demonstrated to reduce turnover. Can we think about a model like that for home care where we at least start to somehow incentivize agencies to start working on more consistent assignment for their home care situations? I'm not saying that will happen overnight, but again, whether it's through a regulatory approach, which I absolutely hate, but unfortunately, the fact is if we just leave providers accountable for their own practice, what we find is the better providers, the ones that really care about this workforce and the families, will do this and the rest of them won't. But are there mechanisms that we could think of?
I just wanted to pick up on that point. Probably a lot of you were involved in the RAISE research I did where I did focus groups, and plenty of people in this room were part of those focus groups. But I'll never forget a guy who was an owner of a home care agency, and he said, if there's it was a private pay one. He said, if there's a problem between a customer and an aide, I'm going to ditch the customer. There are always 4 customers. I want that aide, and I want that aide to stay. Which, really struck me because he knew that a good aide is gold.
Yeah. Mm-hmm. Anybody else have any thoughts about that? Or
I mean, we just know so little from a national standpoint about what is going on, even the number of direct care workers, who's working, what they're doing. We know so little. We've made progress on the nursing home front where we now have data. It's called the payroll-based journal database. We can look at everyone that's walking in a nursing home and getting paid day by day, hour by, not quite hour by hour, week by week. We know who's in a nursing home. So some of this stuff about staffing and the under shortages, that now shows up in federal data, and the nursing homes are supposed to be held accountable for it. Instead of having it before, well, it still happens, but the model of the inspector comes and all of a sudden, right, they call in the emergency staff and they show up, and for the 3 days that the inspector is there, they're fully staffed. Hopefully this will, help to alleviate some of the shortages in nursing homes. We have nothing like that in home health. We get our statistics from wages and employment in home health from the American Community Survey. Right? There's nothing that the agencies are reporting that is getting aggregated up. And so some of it is a data issue. We can't observe, we can't fix what we don't observe, and observing it helps fix things.
And that was raised by several people on a previous panel around the lack of data. I mean, could we think about strategies, and maybe it has to happen state by state, or maybe we can think about a federal effort. I don't know whether AARP has weighed in on this, but is there a way to start thinking about better collection of data? Maybe the registries in many states, home care registries, are starting to move us in that direction. But right now it is tremendously varied. So any ideas about that?
Well, I just wanted to comment that one of our dissertating students, she did a lot of qualitative and quantitative research on home care aides. And, what struck me about that was truly, the issues are very similar across the settings. I mean, there was the same thing about lack of support from superiors. There's the same thing about not being respected in their workplace. There's the same thing about training. The training was a mark of recognition, and not just about the knowledge. It's about recognizing that these people are worth investing in. I mean, it was very, very similar, but you add on the isolation component, which I think really makes a difference. It means that the home care agency just have to be that much more proactive in supporting these people, because they don't get any other support. So I do think we need to have more research like that. It really is very scant. I helped write the paper, and I looked at the lit review, and there was nothing out there. So, yeah.
But I also think that, and I agree, it's really important to have that data. I think not having that data also shows what so many have said, the lack of level of importance that many people give to direct care workers, right? For many different reasons. Because we have data on family caregiving, we have data on what providers are doing, we have data on policies upon policies, but when we look at a core group of people who in this country are really single-handedly working to ensure that individuals in care homes, in personal family homes are cared for, and they're doing it at a lower rate, at a lower wage, but there is not enough data to really talk about their experience at a national level. So I think that's something that we have to look at very closely too. And so many of us in the room are in positions to be in those types of conversations. How are we ensuring that those experiences are showing up and are appearing in data, and qualitatively and quantitatively? It's a call to all of us.
I mean, I just wonder whether the advocacy piece, we talked about the added value of numbers. And if you add all the family caregivers and frontline care professionals together, we have an incredible mass of people, as well as the people who receive the services from them, that could be advocating for this. I don't know how much the data piece is on the radar screen. Robert Espinoza, who is now, I think, consulting with a number of different organizations and used to be at PHI, has talked a lot about this lack of data and whether we can actually push the envelope. I mean, it is one of the fastest growing occupations in the country, if not the fastest growing occupation in the country. And yet we do not have the data. We have to use these proxy databases to actually figure out, get some sense of what this looks like. But we can't even tell the same stories that we can tell about nursing homes because we just don't have the data on that home care workforce. So I'm wondering whether we could think about some advocacy efforts that were either at the national level or through state coalitions to start pushing for it. With the proviso, though, that the data need to be used. I think sometimes we're collecting data now just to collect data. And my feeling is we need to be using it for planning. We also need to be using it for creating an evidence base.
I mean, I also think that the elevation in the last several years of what family caregivers are having to do in the home, you see it in media, you see it on social. I mean, it's not, people like to say family caregivers are invisible. I don't believe that. I believe they're ignored, but they're not invisible. You see what's happening in front of you, right? And so I think that we're reaching a point very quickly where families are saying, we can't do this. It really is unsustainable. And so as those voices become more prevalent, as employers start to lose their employees because they can't afford home care. In the last decade, the expense of home care has increased by 40%. People can't afford that. And so if they're not able to, function and contribute to the economy and do things in the way that have been done because they're having to provide this care in this way, I think we are going to start to see a trend where there's a demand on the advocacy side for things to change.
Just one wrinkle in the let's collect all the data that we can plan. Again, this is care that's provided. Some of it is under Medicare for short term. Some of it is under Medicaid if you want more long term. And, a lot of it is private pay. And so there isn't even the same mechanism to collect a complete universe of direct care workers and the data that we would presumably want because it's so fragmented to begin with.
Yeah, I mean, I will tell you that ASPE, one of the offices I used to work in years ago, is currently trying to develop a new database. They have RTI on contract to work on a feasibility study. And the problem is you do not have one sampling frame. And when you get into either the consumer-directed models where people are hiring independently or the whole private pay market, there's not a way necessarily to capture it unless people are going through an agency. 2007 was the last national survey of home care workers, and that was home care workers who were employed by Medicare certified home health agencies. So it really was a pretty limited database because it didn't include the breadth of the home care workforce. So it's not that it's not a challenge. But I think we could be doing a better job in thinking about how we invest in this. And maybe the registries, if we really had registries throughout the entire country, in every state, we'd have 51 state registries, which includes the various types of home care workers on those registries. So that might be another way of getting a sampling frame. I want to ask also a question about delegation, because I'm not sure everybody understands what that is.
Yeah, I thought.
But I think it's important to tie it back to Rita's point about the complex issues that family caregivers are doing and the potential for the frontline care professional, particularly those coming into the home, to actually do a lot of support work around medication management, some of these other things. In Washington State, because of really strong, very lax, thoughtful, I say thoughtful, nurse delegation, aides can actually administer it. And I'm just wondering, I mean, Heather Young and Susan Reinhardt did a fabulous study. It's somewhat old right now, but it's extremely relevant in terms of the variation in what aides are allowed to do. And I would say on the mental health side, it probably also behooves the National Association of Social Workers and some psychologists to take a look at what could be delegated on the mental health side, because you've got these incredible aides. And all of us know if we've gone in, we've got some people in the audience they're incredible. I mean, they know everything about what's going on with the person that they're caring for. And yet they are not allowed to do certain things, which would be, I think, a fabulous partner for families. So is there a way for us? I mean, the nurse, I don't know if there's nurses in the room, but the nurses it is so hard to get this delegation issue on the radar screen. And it is such an essential piece if we're going to build this frontline staff as real support for the family caregiver and that they really work as a dyad. So I just throw that out. I mean, I'm not terribly optimistic because there's so much pushback around this guild stuff. And when you come out of public health, it's so great because you're not anybody. You're not a clinician in any one profession. But the guild issues really stop this movement of allowing for this delegation, which I think could help so much. So I don't know whether anybody
I worked on this in donkeys years ago, but it was exactly that. The nurses were really politically against this. They felt like it was their responsibility. They felt that these untrained people could not do things correctly. So it was really more of a political issue than anything else. And so I did want to kind of get into the political realm a little bit because, we talk a lot about advocacy. As part of the RAISE work, I did the RAISE and the council. I mean, awareness raising was a big part of it. And one of the projects I'm currently working on is the Community Catalyst, and our group got a grant to work with 10 family caregiving coalitions. And in some of those coalitions, actually, it's workers and caregivers. Anyway, they're sort of doing what they can to raise awareness. And this is going to be a critical thing if we're going to get people mobilized at the state level, which is where people really can have an impact, mobilized and informed and able to get some level of policy change. We've been saying for years, at what point is the critical mass of caregivers going to be enough to, spur people to actually affect change? And, this has been a question I've been interested in for donkey's years. So, it really is in how are we going to get there? And so one of the things I've always speculated, one of my personal hypotheses has been, while people are providing care, it's their world and they have no energy to do advocacy because they have so much to do. They just can't do it. And then once they're done, they want to forget about it because it was a difficult stage of their life. And so they're not necessarily going to. Anyway, I now have data to support this hypothesis. We did a survey and we looked at future, past, and current caregivers. And the knowledge of services and all this kind of stuff drops off once you've got the caregiving experience behind you. That's kind of a negative thing to say in this context, because the hope is we really want these people to live with their experience, and maybe it's only a portion of them have to be excited enough about it to be mobilized and to mobilize others. Anyway,
I mean, and I know time is dwindling, but to your point, I used to think that, and I'm sure the data does show, but I am so energized by younger generations. I am so energized by millennial and Gen Zer caregivers who are saying, what? I did not know I was going to have to do this. I didn't know I was going to have to do it this early. And I'm going to use a platform. And if the platform isn't there, I'm going to create a platform. And I'm going to advocate, and I'm going to use my voice, and I'm going to spread it out over social. And I've been really energized by that. And I think it's really important that those of us that have been in the field for quite some time, as well as newer people, really understand the force there, because I think the younger generations are demanding something more from providers, from politicians, and from their employers, because they're saying we just aren't able to do this, and we need to figure out a way to make this work.
So I know we only have 39 seconds, but I didn't want to end this part of it without having a little conversation around technology whether it's now AI has replaced the word technology. I don't know. I always consider a pen and pencil technology, but that's a different story. Is there a role for public policy to support technology that actually supports the shared care, not necessarily replacing it? And I think that was a comment that was made earlier, but thinking about right now, there is very little incentive for anybody to give the technology to aides in the home to do anything or to share communication with families, except for some models development, which we heard about in the adult day and some other places. Can we think about actually using some of the technology in the Department of Commerce or some of the other organizations that actually have incentivizing programs to actually think about that? So I just wanted to throw that out. I don't know whether anybody has any thoughts on it. And then we'll move to.
I mean, I think the answer is yes. We have ARP has a report coming out next week talking about AI within this space. So I think there's a lot of opportunity for incentivizing as well as making sure that there are some borders up, right? And that we're really cognizant of how we're using that technology.
And I would just, stress the need for it to be not an additional burden on the worker or the family member, because, we all know what it's like sitting there in the doctor's office while they're smoking away at their screen. We don't want that to happen to them.
Many thanks to our panel. We have time for a couple of questions. Ms. Jackson, do you?
Hello, my name is Joyce Jackson. I am a delegate in 1199. I am a senior certified medical assistant / medical office assistant. And my question is about a different community. I have not heard this topic come up since I've been here today. And I service all kinds of people at my job, but I haven't seen, and I live in DC, and it's very little policy toward our HIV and non-HIV gay community. Now, I've had conversations like we're doing now, and it's years. So I think we're like, now the conversation is Trump is in, right? I mean, let's be real.
Yeah.
That's what the conversation is. We need to get past that. We need to get with unions. You need to get with these people, because some of them will go into facilities with other people, but are they comfortable?
Mm-hmm.
They should not have to be subject to.
Mm-hmm.
And these people are not all with Medicaid and Medicare, right? And then once you get somebody that really cares, some of the insurances now are taking away the medication, the time. I do forms for these people that's home health aides. But it's a slow process. What are we doing about that?
Yeah.
So we need to have a form that's actually going to do action. We have a whole union. We have locals that will support, but we need people in Congress and our council. We need federal laws and state laws to agree together. It needs to be the same. Because I don't need to move to Maryland or DC because I can get more over here.
I agree.
It needs to be the same. I can't treat a Marylander different than I treated. We pay taxes. So that's what I would like to see. Thank you, guys.
Hi, good afternoon, everybody. My name is Cynthia Neely. That's my government, but I go by Lollipop, right? Nurse Lolly. So I'm coming up. I don't really have a question. I just want to touch bases with the shared care situation because I've been in healthcare for 5 years now. I've actually been in customer service for over 30 years. I'm 44. So my main thing is satisfying customers and what their needs are. So y'all know I'm a big advocate for the patients as well. The big thing is not accountability. We can have all the shared community things, but we need people to be accountable for the patient-centered care. If you made a mistake or you didn't do something, make sure that you report that to the person that's coming behind you, because we miss that a lot. Accountability is a big thing. With the shared care at home, I think that the owners or management or people that own these agencies and companies should take instead of just having a virtual or on-phone interview to see if we can send aides to help you all, let me come and actually see what the workload is. Let me see what my people are up against when they come into these houses, because a lot of times we go blindsided and we really don't know. I also think that we need to meet the workers that we come behind and in front of, because we don't never see each other. We on the app, it's on GPS, we clock in and we clock out. We document what we did, and that's it, and that's all. I think it should be a meeting once a month for everybody to, meet each other. I think we should have a mandatory training, even if they don't have time to train us, because they never have time. Like I was telling some of the young ladies when we were talking at lunch, that in service is a piece of paper that they put in your face to tell you, hey, when you use a Hoyer lift, you need 2 people. Okay, got it? You can sign a paper. And that's just it, And a lot of younger people that's coming behind us, they care not to even listen or hear what really the care that they need, because they just there to make money. And one of y'all stated earlier that once they get in there, they think it's something different. Like, oh, this is not, I didn't know I had to do it right now. Like later on, no, you have to do it as soon as you step foot in these people's houses, facilities, long-term care, assisted living. I work for 2 nursing homes and I do home care as well. So in a nursing home, I also think that the admission, the staff, the HR, like the people that's in the that's paying us and giving us these trainings, I want them to put the scrubs on once, pick a day in a month. Everybody is like 10 of them. One of y'all pick a day just to work and shadow the DNA and the CNA and the nurses to see what they actually really are up against, like how these customers are, how the family come in and treat us when we're doing 100% to make sure that the patient is where they need to be. When we short on staff, we can't give them patient-centered care because all we can do is change them, dress them, and get them ready for appointment or rehab. We can't put lotion on their face. We can't do their hair, give them a braid or 2 because we're short-staffed. So we gotta move fast. We have feeders. A lot of the younger generations, they don't want to feed them. They think, oh, they don't want to eat. And I also made a statement that when anyone is in assisted living, long-term care, rehab, they have a lifestyle that they lived before they got ill. They have a lifestyle before they got sick or any mental illness or disabilities they have. So if they want to brush their teeth at night, help them brush their teeth at night. You have time to do that. So that's what I was touching bases on. And also, I want to keep this in mind for you. I want y'all to keep this in mind. My 2 sisters, my 2 nursing sisters, they've been in this for 20, 30 years. They've been fighting for 20, 30 years. I've been in it for 5. I've been with Caring Cross American, Maryland, testifying in Annapolis and all this stuff. When is somebody really going to hear us? When are we really going to be heard? They've been doing it for 20, 30 years and nothing has changed.
Yeah, Molly, this was just great for you. I would say amen to that.
Yeah, I just, want to say, those points were brought up, that handoffs are critical. So if you're handing off and the person who was before you doesn't tell you what happened, if there's no opportunity for communication, right? You pick up a new patient, you want to hear, what the person before you had to say. You need connection so you can exchange, good practice amongst, fellow staff. Because like I said, isolation is the big thing. So you don't have anyone to bounce ideas off of.
No.
All of those things are critical.
Thank you.
Thank you for saying that.
Thank you. And I know Jennifer has a question, and then we're going to break for about 10 minutes. I want to lift up this one comment in the chat just so it doesn't get lost. But then Jennifer, please, on delegation, just thinking about lifting up the issue of liability playing out, and how the panel has discussed the issue of delegation.
Yeah, and this isn't a question, it's really more of a comment for everyone in the room to be thinking about, because I am really struck by the idea of coalitions that came up this morning, and how I've taken away is the value of having diverse perspectives in the room together, thinking about an important topic we all care about. And this issue of evidence is really important. There is a lack of data on the direct care workforce in nursing homes, but even more so in the home. And to the direct care workers in the room, it's so valuable to hear your perspective. It's incredibly important. We have no national information on what your experiences are. And I will say, from working closely with Dr. Fabius and being involved in other data collection activities, it's really hard to find you. There are efforts to try to find and be able to study the direct care workforce so that we can be able to monitor how things are going and how things could go better. But these studies are failing because there's no way to find you. So it's really a problem on all different levels. And I'd love for us to be thinking together, how do we move the work forward? Because when we think about where, Rita's point, you can find caregivers, but you can't listen to them, or they don't have an influence. Like, I think that the data really speak. And if we think about the patient safety movement, a lot of momentum came out of studying gaps. And so if there are gaps, we need to be able to talk about them, but we need the data. So for the direct care workers in the room, how do we find you? We need to hear from you how to be successful in our effort to be able to study and be able to provide more evidence to be able to motivate change. Thanks.
Thank you. And with that, we're going to take about a 10-minute break and then stretch your legs, get some coffee. There may be some snacks back there. At least, I don't know. But there may be some snacks back there, and then we'll come back for our final panel and the rest of the day.